Greetings, this is Dr. Joseph Sarkissian. Today we have an interesting case to present. We have an implant to be placed on the upper right first molar area, which will require 2 to 3 millimeters of a crestal sinus lift in order to accommodate a 10 millimeter zirconia ceramic implant. The implant of choice is a tissue-level zirconia metal-free implant manufactured by the Swiss company Zsystems. This system features an abutment with a conical connection and which is screwed in with a likewise ceramic screw. Therefore, all components are metal-free. The cone beam study simulates a 10 millimeter tissue level implant by Zsystems, as mentioned, and a surgical guide is manufactured based on that. This guide is a pilot drill only, and I mark the entry point and create a small flap papilla sparing that will displace keratinized tissue to the facial of the implant. This is one of the greatest benefits of using this style of implant because it has a tulip that will create a physical barrier for the keratinized tissue to be sutured on the buccal aspect of the implant. To help in visualizing the situation, I have included some sketches that I myself have produced to demonstrate the whole procedure. Remember, this is a semi-guided surgical guide, which is intended for just the pilot drill. So the pilot drill will have to be introduced and has to stop 2 millimeters before the floor of the sinus. So far, I know from my cone beam study that the bone height is 8 millimeters. When I insert the surgical guide, I then probe the opening until I hit bone, and I measure that distance. Let's assume to be 10 millimeters. Therefore, my drill depth from the top of my surgical guide platform to where I should stop is now 10 plus 6, which is 16 millimeters. I measure the pilot drill just for reference and proceed to drill into the bone, but I stop even shorter than my target depth. This is in order to make sure that I take an X-ray with a pin to ascertain my correct angulation and depth, which reveals that I have to drill just maybe 2 more millimeters until I reach my target depth of 2 millimeters short of the sinus floor. Throughout the following sequence of successive osteotomies with the zirconia burrs, which also have a stop to prevent exceeding the desired depth, we are using a probe to sound the bone and also to make sure that we have not perforated the sinus membrane. I am now enlarging the osteotomy to almost the same diameter as my sinus lift punch. This is not the most pleasant of sensations, but I have warned the patient that he will feel quite an annoying hammering into his jawbone. There are calibration lines on this instrument. We can follow the advancement of the instrument as it punches through the bone and slowly lifts it up. The force of the tapping has to be well controlled and measured so we avoid accidentally tearing the membrane. This plug of bone that is pushed upwards also pushes and separates the membrane up just like a tent, which will give us the additional few millimeters for the sinus lift in order to accommodate the implant. Now this space can also be filled with PRF or particulate graft. Now in order to test if there's a tear in the membrane, we gently probe inside the osteotomy and push it up very gently to see if there's any elasticity, just like a trampoline. I also repeatedly conduct the Valsalva test, which involves blocking the patient's nose and instructing them to blow. When you see bubbles emerging from the osteotomy, that indicates that the Schneiderian membrane is torn. Now, if it's a very small tear and you are not inserting particulate graft, you can still insert the implant. However, if it is a large tear, then you just abort and do not place the implant. Now I'm ready to do my final osteotomy with the final size, 5 millimeters by 10 millimeters. Because we are using the tissue level, we also have to do a slight countersink to accommodate the tulip. I have preset my insertion instrument for 35 Newton centimeter and hope that we will achieve this torque. The displacement of the keratinized tissue is of absolute importance. I do this almost every time with my implants, and I gently fix it to the facial of the tulip of the implant with 2 PTFE 40 sutures. The patient is instructed to wear a carefully constructed Essex, which he is required to wear 24/7 for 2 months so that nothing touches the implant while it's healing. The sutures are removed in 3 weeks and the implant is restored in 5 months. The implant is a success. And here in the final X-ray, we can follow the elevated part of the bone as part of the crestal sinus lift.